Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and we are a national organization that convenes diverse stakeholders across the healthcare landscape who are committed to improving the nation's health by strengthening primary care. I'm delighted to be welcoming you to today's discussion with CMS leaders on how proposed changes to Medicare Part B policy will help improve seniors' health by strengthening primary care. But before we introduce our guests and get started, a couple of housekeeping items. Like all of our webinars, this is being recorded and will be available for viewing on PCC's website within 24 to 48 hours. Due to time constraints, our CMS colleagues will not be taking questions submitted during the webinar live, but we have gathered questions in advance and we will be asking them. In the meantime, if you do have questions, you can put them into the chat and staff who are joining us from CMS will respond to them. We will also be sharing a link for follow-up questions of our CMS colleagues. We will be taking questions during the reactor panel, which will follow the presentation by our CMS colleagues. Now, I'm thrilled to kick off our conversation with two phenomenal leaders from CMS. Dr. Meena Seshamani is Deputy Administrator of CMS and the Director of Medicare. Dr. Liz Fowler is the Deputy Administrator of CMS and Director of the CMS Innovation Center. Meena, Liz, we're thrilled to have you with us today. Thank you.
Thank you so much, Anne. It's really great to be here with all of you. And it is a very exciting time for primary care. We're looking forward to sharing with you updates from our recently proposed physician fee schedule and to engage in the conversation. And I think ultimately what all of this comes from is our firm belief that a person-centered approach to healthcare starts with a trusting relationship with the primary care team. Now, over the last decade, value-based primary care models tested by the CMS Innovation Center have demonstrated that comprehensive primary care can lead to reductions in emergency department and hospital visits while better meeting patient needs. CMS is proposing to use these lessons that have been learned to establish a new advanced primary care management bundle under the physician fee schedule. This is an important first step as part of a multi-year effort, and this proposed payment uses coding describing certain primary care services that would be provided by advanced primary care teams, with adjustments for patients' medical and social complexity to promote health equity. These services would also be tied to primary care quality measures to improve health outcomes for people with Medicare. And I'll turn it to Liz to give the CMMI side.
Meena. Building on Meena's remarks, I think what you've been seeing coming from the Innovation Center is that there's more than one way to scale Innovation Center learnings and model tests. And we've been looking at ways of using those learnings to embed innovations permanently into the Medicare program. And that's been a top priority for CMS in our mission to support and bolster primary care. Working across CMS is really the most effective way to achieve this goal of scaling our innovations. A recent example of this approach is the Innovation Center's ACO investment model, which is now a permanent part of the program in the Medicare Shared Savings Program as the Advanced Investment Payments Program. And then another example, earlier this year, we announced the ACO PC Flex model, an advanced primary care model that we'll be testing within SSP starting in January 2025. For ACOs already in or that have applied to SSP, there is still time to apply to ACO PC Flex. The deadline is August 1st. And just a shout out to Anne and PCC for their instrumental role in shaping that model. And now, as part of our multi-pronged strategy to support and grow access to advanced primary care elements that are shown to work, like team-based care and care coordination, The Innovation Center has partnered with colleagues in the Center for Medicare, Mina and her team, to propose these new advanced primary care management codes in the PFS. And the Center for Medicare and the Innovation Center have worked closely in crafting the request for information on potential payment policies to further support advanced primary care. Mina,
So
I think you're going to
with,
pass it back
yeah,
over.
I think with that, hopefully you all see, how closely our centers are working together and how central supporting primary care is to our joint mission. And so with that, I'll turn it over to Dr. Doug Jacobs, who's the Chief Transformation Officer in the Center for Medicare, to walk through the specific advanced primary care codes that we've referred to here.
Thank you so much, Dr. Sishmani and Dr. Fowler. It's really a pleasure to be with you all here today. My name is Doug Jacobs. I'm going to be going through some of the primary care related changes in the physician fee schedule proposed rule for this year. I'll also be joined by Dr. Purva Rawal, who will talk more about the request for information. So just as a disclaimer, as I get started, what I'm going to be talking about today is related to the proposed 2025 physician fee schedule. It's more at a summary level, and so for all the details that that you need, really go to the rule and read it. And the comment period is a 60-day comment period. It's open until September 9th. We really do take a lot of those comments into consideration and read through them all. So this is just intended to give you the summary, but please do some additional reading as well. So with that said, and Mina and Liz had covered this, a strong foundational primary care system is fundamental to improving health outcomes, lowering mortality, and reducing health disparities. That's why HHS has broadly been taking action to strengthen primary care, and this is the most recent example of that with the Advanced Primary Care Management Services. I'll be talking about them with the abbreviations APCM, so that stands for Advanced Primary Care Management. So this new coding and payment would better recognize and describe advanced primary care services, support primary care practice transformation, and help ensure that patients have access to high quality primary care. And also would simplify billing requirements, and I'll get into that more as well. And as was just discussed, this is really built on the 10 plus years of lessons learned from Innovation Center model tests, including CPC Plus and Primary Care First. So getting into these codes specifically, for 2025, we're proposing to establish coding for 3 specific APCM codes. And these codes could be billed by both physicians and non-physician practitioners. That includes NPs, PAs, CNSs. And those practitioners who are billing would have to be responsible for all primary care services and also the focal point of all needed healthcare. And so that really indicates that this is the primary care relationship that we're focused on here. So these proposed services would incorporate several different types of care management services, such as chronic care management, principal care management, transitional care management, and also what's called the communication technology-based services. So that includes things like virtual check-ins, the codes related to interpreting an image sent by a patient, and others. And it would also remove some of the burdensome elements of billing and coding individual care management codes. Care management codes currently have time-based billing requirements. So every minute that's spent for chronic care management needs to be documented, and you need to hit a certain threshold every month to bill those services. These services are not time-based, meaning that they could be billed per patient per month. And we anticipate that sometimes services would be more in a month, and sometimes services would be less in a month. And we do have instead stratification based on the type of patient that is being served by these services, which I'll talk about now. So there's really 3 levels of these advanced primary care services. The first level, level 1, is for patients with 1 or fewer chronic conditions. And that's because primary care services are for everybody, and everybody can stand to benefit from going to an advanced primary care practice. including people with 0 chronic conditions. The relative value unit, or RVU, attached to this is lower because the expected utilization would be lower. So the proposed RVU is 0.17, which translates to about $10. I will say the caveat with giving dollar values is that can change on any given year based on the conversion factor changes and also based on where those services are being performed geographically. So level 2 is for patients with 2 or more chronic conditions. In Medicare in particular, we anticipate a lot of individuals would fall into this bucket. That is associated with a proposed relative value units of 0.77 or about $50 with the same caveats that I described earlier. Level 3 incorporates not just the medical complexity, 2 or more chronic conditions, but also a level of social complexity. And the way that we're identifying that is the qualified Medicare beneficiary status. That means that the individual is dually eligible and also is not eligible for cost sharing, which is important because, like all Part B services, these services would have cost sharing otherwise. And the relative value unit here is much greater, given that there would be a much higher expected utilization per patient this is billed for per month. Okay, so with that, because there's no time-based billing, and we're also trying to capture advanced primary care services, there's also specific service elements and practice level capabilities that I'm going to go over now. And the first part of this is consent. So the patient needs to be informed as to the service, what it entails, the fact that only one practitioner can bill the service during any calendar month, the right to stop the service at any time, and that cost sharing may apply. I say because a lot of individuals, I think as folks might know, have supplemental insurance and Medicare and don't have to pay cost sharing, or like was described earlier, certain duals don't have to pay cost sharing as well. Additionally, there's a requirement for initiating visit for new patients. And so by new patients, we mean individuals who have not been seen by the practice or the practitioner in the last 3 years, or have not received a care management visit in the last year as well. And that is sufficiently broad that ACOs and advanced primary care models, that captures some of the attribution methodology that already exists there. The next requirement is 24/7 access to care and care continuity. The 24/7 access is for urgent needs, providing patients and caregivers with some way to contact healthcare professionals. That could be, for example, an on-call service. And care continuity, we mean that there's a designated team member that the patient can have continuous successive follow-up with. Additionally, I talked about how care management is involved in these services, and a key part of that is comprehensive care management. So that means a needs assessment, ensuring that patients getting needed preventative care services and medication management. The other part of care management includes a comprehensive care plan, and that's a care plan that's patient-centered, that the patient can access electronically as it gets updated as their care progresses. Additionally, management of care transitions. We know this is an important piece when a patient gets discharged from a hospital or skilled nursing facility, that there is some kind of communication with the primary care team and that patient. And so we're proposing that take place within 7 days. Also, practitioner, home, and community-based care coordination. Different individuals have a different looking team of specialists, and perhaps home health might be involved, perhaps community-based organizations providing social services might be involved. And so depending on what their team looks like, making sure the care is coordinated. And also enhanced communication opportunities. What we mean by that is what we oftentimes call asynchronous, non-face-to-face communication. Basically, that means something like a patient portal message, or the ability of patients to message their providers through that. These last two have to do with quality improvement and quality measurement. And so patient population level management, the requirement here is essentially for the practice to look across their patient panel, identify patients at risk and care gaps, and close those care gaps. That goes hand in hand with this next and last requirement related to performance measurement. So the requirement here is to be measured on quality measures related to primary care, the total cost of care, and also meaningful use of certified EHR technology. We've specified that providers can satisfy that by reporting the MIPS value pathway, or MVP, in Medicare. And also that this would be satisfied if you're part of an ACO or an advanced primary care model that has quality measurement as part of it, like the Shared Savings Program, ACO REACH, Making Care Primary. That also satisfies this requirement as well. And same with the patient population level management. The ACOs and advanced primary care models satisfy that criteria as well. So definitely look more in detail. This is the reference here is table 21 in the proposed rule for more information. And some other areas that I just wanted to touch upon with this. I talked about some of the MIPS value pathway. The way that that works in general for MVP reporting is for care rendered in 2025, the MIPS value pathway, or MVP, gets reported in the first quarter of 2026. That then affects payment in subsequent year 2027. And the other areas that I just wanted to highlight really quickly. So we're really trying to promote team-based care. And so these services can be provided by auxiliary personnel, that's clinical staff, under the general supervision of the billing practitioner, who's either a physician, nurse practitioner, a PA, and CNS. And we also talk about in the proposal how you can't bill for both these services that are described here and the duplicate services of care management and the communication technology based services as well. So I mentioned that this is going to be an iterative process, and so I wanted to introduce Dr. Purva Rawal, the Chief Strategy Officer in the Innovation Center, who's going to talk more about the RFI.
Thank you, Doug, and a big thank you to Anne and the PCC team for the chance to speak with you all today. As my colleagues have mentioned in their remarks, the APCM bundle is the first step in what we hope to be a multi-year effort that will hopefully further strengthen the nation's primary care infrastructure and beneficiaries' access to advanced primary care, which we know leads to better health and better outcomes. As many of you know, the Innovation Center has long been committed to supporting primary care transformation through increased investments, regulatory flexibilities, increased access to tools and data, and other supports through many of our models, our comprehensive primary care model, our comprehensive primary care plus model, primary care first, and now our Making Care Primary models. We are so thrilled to be working with the Center for Medicare on this year's proposals. And together we know we have more to do if we want to achieve longitudinal accountable care relationships more broadly in Medicare. And so to that end, we are seeking comment through a request for information that's been included in the NPRM on how we may be able to build on the APCM bundle to design a future hybrid primary care payment that incentivizes and accurately pays for advanced team-based primary care capabilities that we know, based on our experience, will yield improved patient outcomes. Specifically, as you see here, we're requesting input across 5 major design categories related to care delivery and payment. The first is streamlined value-based care opportunities. This includes feedback on ways to reduce barriers and to create multiple pathways to recognize the delivery of integrated care across settings and engagement in comprehensive team-based longitudinal care. The second is billing requirements. So the goal of better understanding how hybrid payments can balance program integrity, high quality care, payment stability, and very importantly, I know many of you are interested in ways that we can also reduce clinician burden. The third area is person-centered care, so focusing on how we can strive for better, more affordable care and outcomes while ensuring beneficiaries and clinicians aren't overburdened through that process. The fourth is health equity, clinical and social risk. We're seeking input on how billing and payment policy can be used to reduce health disparities and social risk. And then the fifth and final area is quality improvement and accountability. We're gathering feedback on the balance between ensuring patients are truly in meaningful, accountable care relationships with the realities of quality data collection and measurement challenges. So we are so thrilled and excited about this next step and hope you'll consider commenting on the RFI. We're accepting comments through September 9th, and just want to thank you, many of you, for joining today, and I'm looking forward to hearing more of your questions and reactions from today's panelists.
Thank you so much, Purva. So Just really quickly, there's so much packed into this rule that we'd be remiss if we didn't quickly highlight some of the other areas to take a closer look at. The first is we made some additional proposals related to the outpatient complexity add-on code G2211, allowing it to be billed with annual wellness visits, vaccine administration, or Medicare Part B preventative services. Additionally, in the same vein of using lessons learned and scaling them into the Medicare physician fee schedule as permanent aspects of the program, the Innovation Center's Million Hearts model had a demonstrated mortality benefit. And so we are proposing creating new codes related to cardiovascular risk assessment and management related to that model. And then finally, there's another code that we propose related to capturing some of the time and resources involved in postoperative care when it's done by practitioners who weren't involved in the furnishing of the surgical procedure. This can oftentimes happen in the setting of primary care, and so we wanted to just highlight that as well. So with that, I know that was a lot of information. We'll be happy to take some questions.
Well, thank you so much, Doug and Purva. Clearly, this represents a tremendous amount of work, and also the two parts of the administration that haven't always worked so closely together. So really appreciate this. We did get some questions in advance, and we'll take a couple of minutes to pose them to you. You know, some of past attempts to improve payment for primary care have required quite a lot in terms of reporting burden. I'm curious, what steps are you taking? And you alluded to this, but if you could provide a little more detail to make sure that this new, more comprehensive code is not administratively burdensome for folks to report.
Yeah, thanks so much for the question. So we have heard over time that, for example, with the care management codes, part of the main barriers to reporting them is the need to document every minute that is being delivered, and also needing to hit certain thresholds to be able to bill the services. These codes get rid of some of those administrative barriers. There is no time-based billing requirement. There's no minimum threshold of minutes that you need to reach every month in order to be able to bill the codes. And we do that because the understanding is there's going to be some months where there's likely less of this care that's provided, some month where there's likely more of this care that's provided. And so we tried to value them as somewhat of an average monthly rate. And then the other piece that we're trying to do to reduce some of this administrative burden is ACOs, or advanced primary care models, that are already fulfilling a lot of these requirements. There's a lot of there's several requirements that they no longer need to meet, or they meet it by virtue of being in the model or ACO. And so that was done deliberately. A lot of these codes reflect the lessons learned from these advanced primary care models over time. And so it's still our intent to we think that these codes will build an additional pathway and are a step towards accountable care and encourage movement into accountable care organizations as well.
Super. And hopefully practices that haven't participated, or individuals will get in the game if there's less burden for reporting. The RFI is a pleasure to read. I commend it to everyone. Thanks for your overview, Purva. In the RFI, you ask explicitly for perspectives from other payers. And how are you all thinking about alignment across other payers?
Yeah, multi-payer alignment has been such an important part of our Innovation Center model test in the advanced primary care space, and we continue to try to find new ways of aligning with Medicaid and commercial payers, and this continues to be a focus in Making Care Primary, as you know, Anne. So to that end, we're actually asking a number of questions about how a future hybrid payment option could be used to promote accountable care, both in commercial and among Medicaid payers. So some of the questions that we're asking, for instance, are what quality measures are other payers using to drive improvements in primary care? What kinds of utilization measures are they using? And what kinds of patient experience measures are other payers using to improve the primary care experience for patients? So definitely an area of focus for the RFI, and looking forward to comments.
So we hope that all stakeholder groups respond to this RFI and provide some of those insights. How can the proposed APCM service support broader adoption of behavioral health integration? I know there are a number of facets that speak to behavioral health services, but how do you think now or in the future we might achieve what has been an administration goal and a goal of the PCC to better integrate behavioral health into primary care?
Thank you so much. This is a high-level goal that we share as well as part of our broader behavioral health strategy. We know a lot of patients get their primary care they get their behavioral health through their primary care. And so for this initial year, we are not proposing to include behavioral health integration services as part of this bundle. That means that behavioral health integration could continue to be billed outside of this bundle. We have been taking separate steps to strengthen those codes, make behavioral health integration more applicable to varying situations, allowing LCSWs, MFTs, MHCs to bill for behavioral health integration. And we also ask, building on some of the RFI questions, we ask about this in the RFI too. One other quick note is with these services as well, when CMS finalizes a code, it can be used across payers. And so that is part of what also can build multi-payer alignment in the long term. And and other payers, commercial payers, state Medicaid programs can use the codes. I will also say that CPT committee oftentimes picks these codes up as well, and has done so, for example, from the previous care management codes too.
Well, thank you both so much for your quick overview. I know that PCC members and others in the community look forward to responding to the RFI and also to the draft rule. Appreciate all the hard work. And now I'm going to welcome a group of panelists who are going to react to your comments today, and we'll continue the conversation. Thank you again. First, I'd like to welcome Sarah Coombs. She's Director for Health System Transformation at the National Partnership for Women and Families, where she manages policy and programmatic work on health access and system transformation. Prior to the National Partnership, she was at the Office of the Secretary of the Department of Health and Human Services, a colleague of Dr. Seshamani. Sarah is also co-chair, along with Sherry Erickson of the American College of Physicians, of PCC's Policy and Advocacy Committee. Next, I'd like to welcome Dr. Amy Milowiski McKenzie, Vice President of Clinical Partnership and Associate Chief Medical Officer, Blue Cross Blue Shield of Michigan. She is a board certified family medicine physician and serves on Michigan Certificate of Need Commission. Both the National Partnership and Blue Cross Blue Shield of Michigan are longtime PCC members. Welcome to both of you. Finally, I'd like to welcome Dr. Amol Navathe, who's the Vice Chair of MedPAC, the founding director of the Parity Center, co-director of the Healthcare Transformation Institute, and associate director of the Center for Health Incentives and Behavioral Economics in the Department of Medical Ethics and at the University of Pennsylvania Perelman School of Medicine. He's also a professor at Penn and staff physician at the VA Medical Center in Philadelphia. Well, you can see we have an incredible panel, and these are exactly the sorts of perspectives that I am sure CMS welcomes and will appreciate as they receive comments from you and from your colleagues. Let me start with you, Amol. I think we are all very familiar with the 2021 National Academy of Science and Engineering and Medicine report that reviewed decades of evidence related to primary care and produced a landmark report. One of the key recommendations that this report advanced in order to ensure that Americans live healthier lives was to transform how and how much we pay primary care. In your review of the draft rule, how much does it move us in that direction and how far?
Sure. Thank you, Anne, so much for having me today. Happy to give some thoughts. So, I think first, real kudos to the CMS team. I think as we heard from them, a very thoughtful step forward. I think there are aspects here, ultimately, the context here, of course, is fee-for-service Medicare in some sense. And the actions that they've taken here to really try to simplify coding, actually bring more dollars into the codes to try to kind of simplify the administrative aspects of this, and make this available to physicians and non-physicians alike who are providing primary care. I think these are really important dimensions that are clearly steps forward that reflect the multi-year plan that they have. And I think major kudos to them. I think, and you highlighted that this is the CM, so the group that runs fee-for-service, as well as the CMS Innovation Center, led by Liz, which is trying to really push forward advanced models coming together. And I think we can see some aspects of that. Some key dimensions to be thoughtful, to kind of inform future directions. So, one of the things that was highlighted here, of course, is that this is only available to clinicians who are in an advanced model. This is not for all the primary care clinicians across the Medicare program. And I think that's kind of one big question for us, is if we're really going to transform the whole primary care system nationwide, how much change is needed? How much flexibility is needed? Do we have the evidence to really take that next step forward? And I think the CMS team here has highlighted the number of demonstrations that have happened in the primary care space that they're kind of building upon. And I think the transformation that the National Academies highlighted, it's not going to happen through fee-for-service alone. I think we heard a little bit about the RFI for the hybrid payment system. So I think that's great. That signals where we're headed in some sense. I think Medicare has to be a leader here. We've seen from some other contexts, such as private payer-led initiatives, that you really need scale to initiate the type of transformation that we need. So Medicare has to be a key player here. And the last thing that I'll mention is probably the most challenging piece, I think, is the quality measurement aspect. There's an aspect of quality measurement, which is, are we following evidence-based practices? That's certainly important. I think that's where a lot of the effort and measurement infrastructure is right now. That's different than, are we enabling practice transformation? How do we do that without really stimulating a ton of administrative burden? I think that's the real critical, challenging question to me. The payment piece of this, we've demonstrated feasibility in other settings. I think we can do that part.
Thanks so much for those comments. Please put your questions into the chat, and we'll circle back. Let me now ask Sarah a question. Equity has been a priority for this administration. And we know primary care is the one part of our healthcare system where more of it consistently is associated with improved equity. How far can we move towards health equity? How much can we do to resolve historic underinvestment as long as fee-for-service remains the dominant payment methodology?
Yeah, that's a great question. And thank you for having me and to the CMS leadership team for all the great, wonderful work you all are doing to strengthen primary care. So as everyone has mentioned on this call, a strong primary care system with a strong primary care workforce is foundational to an efficient, high quality, and equitable healthcare system, full stop, period, right? And so as long as fee-for-service remains the dominant payment methodology and primary care services are undervalued, then I do not think that we will get very far in advancing health equity. And to be clear, payment, or rather, how and how much we pay for care is just one of many tools or mechanisms, albeit a very important one, to improve health equity. But to get to a state, of health equity, and we know it essentially requires, and this is probably too simplistic, but it requires, that everyone has the resources and opportunities they need to achieve optimal health. We know that the predominant fee-for-service system is just not designed to do this. It limits the delivery of flexible, personalized care that people want and need. It fails to adequately pay primary care services that are essential for promoting health equity. And it does not hold providers accountable for the total cost of care, quality, and equity of care. Although, as others mentioned on this call, I think the APC&M codes, or the bundle, is really a step forward in the right direction and moving us towards a value-based care system. I think that is a really strong component of this proposed rule. So on the contrary, a value-based care system really has the potential to pay providers in ways that can encourage and hold them accountable to improving health outcomes. But I think it's also important to be clear that a value-based care system in and of itself is not going to advance health equity if it's not designed from its core to address health inequities and center historically marginalized communities and partner with patients and communities. I think one other important thing that I'd like to note related to health equity, but it's important for all Medicare beneficiaries, especially those that do not have supplemental Medicare plans or are not a qualified Medicare beneficiary, that care that I think Doug mentioned, Dr. Douglas Jacobs mentioned, that care management coding and payment does require beneficiary cost sharing, which is a large barrier for many beneficiaries, half of whom have had incomes under $36,000 a year in 2023, and 3 in 10 of which spent more than half their income on their healthcare in 2022. And so we know that those are barriers that relate to lower utilization of primary care and preventive services, and actually prevent greater uptake of chronic care management codes. And so while there are groups of beneficiaries that may not have cost sharing, there's also many others that do. And I think we do need a statutory solution to address this issue. And we see that effort underway now in Congress. So that's really reassuring. But overall, just very pleased with CMS's overarching primary care strategy, recognizing that effective primary care is really essential for improving equity.
Thanks so much, Sarah. Amol, I think you wanted to weigh in as well.
Yeah, so I think Sarah highlighted a bunch of really important things. I think the cost sharing point, Sarah, that you mentioned is just spot on. I think the other piece that's just worth keeping in mind about the equity piece is, if we look at the historical paradigm of the TCM, CCM codes, there was very unequal lack of uniform use. And I think we found in underserved areas where we have disparities challenges, that's where we really didn't see take up of those codes. Hopefully this is a step in the right direction to simplify. I think one of the challenges that CMS and the administration and others are going to have to really think through in this context of a multi-year stepwise plan is, anytime we make changes, it does require resources, reconfiguration. That's essentially, in some sense, a quasi-unfunded mandate, and that's always going to be harder for practices that have less resources. So I think it is worth thinking forward here about how we unroll this, so that our intentions really match the outcome that we're after here.
Thanks so much for that comment. I think the other thing, when you read the rule and look at the RFI that is stressed, is this notion of a bundled payment being able to support a relationship between a beneficiary and a primary care clinician. And I think that's also an important component and contributor to better patient experience and better patient outcomes and more equity in care. So, I think there's, as you pointed out, addressing the beneficiary copay is going to be very important, but also just the form of payment can help in strengthening that relationship. And I think that's going to be, a really important contributor. Mindful of, I think, the things that you've raised, Amol, about anytime there's a change, it does require retooling, and that takes resources. So over to you, Amy. You oversee many primary care physicians and other clinicians at Blue Cross Blue Shield of Michigan. And I'm curious, as you review the rule and talk with your team, how do you think it might help primary care clinicians make important delivery changes? How do you think it might contribute to reductions, hopefully, in administrative burden? And what additional steps do you think we need to take to really support primary care so that it can realize its promise of really improving population health, closing equity gaps, and yes, even beginning to reduce costs.
Yeah, thanks, Anne. And thanks for the opportunity to be here today. Like the other speakers, first off, I would like to applaud PCC for kind of bringing this topic, but then also CMS for the steps they are taking and the leadership they are taking to support primary care, because I do feel like these steps are very beneficial. We've heard about the challenges with the CCM codes, the TCM codes. One of the things we see with our primary care physicians is there just are so many different ways to code for care management and transitions and support for coordination that it gets very confusing. And part of the work we've done here in Michigan, not only in supporting that payment, but is also helping to support them to understand how they need to code. But it's still challenging. You need a lot of resources within the practice. And so it worries us, especially for those smaller and independent practices that are in those more rural areas. And that's where we see disparities in the ability to deliver these services. Either they don't get delivered, or sometimes they're delivering them and not getting paid for them. That's not a sustainable way to run a practice. We know that physicians, primary care has been underfunded. They need payment for the services that they deliver. And when we put payment there, those services we're going to see more adoption of those services. So creating these bundles, and then also looking at how care is evolving and how patients want to be able to receive care. So being able to now get payment that's bundled in for those virtual services. So I do think this is going to decrease the administrative burden. I think coming up with the codes helps with multi-payer adoption. Again, if you don't see multiple payers moving in the direction of creating payment, it just becomes too complicated for the offices, and they're not going to do it. So, again, I applaud this. I think it's really definitely a step in the right direction, creating those bundled payments. In terms of where we need to go, I'm going to reflect on some of the things that the other speakers said. We need consistency in reporting, consistency in expectation for physicians, as well as, how they're being measured. I think this rule is also moving in the direction of helping to create some of those criteria by tying it through to the other advanced primary care models. I think there are other things that we're going to have to continue to think about. I do have concerns about the cost share. When we initially started paying on CCM codes, we had cost share tied to it. We saw low adoption and lots of abrasion with patients. It also is going to, I think, get in the way of trying to reduce disparities. So I think that's going to have to be thought through. I was excited to hear the leaders at CMS talk about that they are thinking about behavioral health integration. We've moved forward with our team-based care models at creating payment for things like collaborative care. But then I also would emphasize, and I think Amol was just speaking about this, just putting the payment in place doesn't get us there. We have to really think about how do we support these physicians in transforming the care within their practices. And that requires a lot of training, peer support for others that have done it is what we have found to be very beneficial. And then kind of ongoing discussions of how do I overcome some of these barriers in my office so that people aren't trying to reinvent the wheel. They can learn from one another, and creating that kind of learning environment. We've been very fortunate here in Michigan that we have kind of multi-payer participation along with provider leaders within the state that have helped us to kind of craft this and move this along. But, CMS stepping into this and creating those codes does create some of that, that stakeholder buy-in, and also the scale that we're going to need to get these things moved forward. So really applaud the efforts.
Thank you so much, Amy. And Blue Cross Blue Shield of Michigan has been a real leader in moving forward behavioral health integration. And I remember when you all did a webinar with us a couple of years back, and your conclusions after working on behavioral health integration into the PCMH model was that in order to make it successful, you had to plus up the codes to make it financially viable. You needed to waive the beneficiary copay, and then you really needed to provide TA to help practices make the care transformation possible. So, it's exciting to see these efforts, but we also know that they need to be accompanied with leadership from organizations in the public and private sector, advocacy work on the Hill to deal with the beneficiary copay issues, and many other efforts to successfully move this forward. So it will take a village, and I think for some of these changes to happen in a way that really does support primary care. We're all going to have to work together going forward. CMS has taken some steps to, lay out a vision. They've worked across various leaders in the administration to do a lot in the thought leadership space, putting out articles in Health Affairs Forefront and in the peer-reviewed literature as well. What do we think, in addition to some of the things that I've mentioned, what do you all think that we need to do as a community to inform and shape the implementation of the vision that they have laid out?
Yeah, I can start. I'm going to circle back to kind of, the rule and the payment structure is helpful, but I think it's going to really require these kind of on the ground of how are we going to get there, right? It's engaging our, physician provider stakeholders in the community. It's engaging with other payers and figuring out how do we help the practices be able to transform their offices in order to be able to deliver high quality team-based care and behavioral health integration. And that's going to mean, different things for different regions of the country. What we found here successful in Michigan is providing some of that support mechanism. We have some centralized support that helps physicians understand the billing requirements, that understands what the care models look like, and get very tactical about how should this look in my office and where can my people get trained in order to kind of get the implementation move forward. Others may have different perspectives, but that's been our experience here. And then thinking about how we reduce barriers, like how do we take down cost share and things that are going to get in the way.
Yeah, this is Amol. I think I would definitely agree with what Amy is saying. I would say, to some extent, as Anne, you and your organization have done a great job of facilitating this engagement. I think getting engaged is really important. Give your feedback. Get in there and talk about the on the ground point of care experiences in these models. Because I think ultimately, as we're seeing in this multi-year vision, in some sense, this is a template for what will come. It's a template for what might get scaled more broadly. And I think the reality is that we want the care model to drive the payment model, not the payment model to drive the care model. And I think despite its best efforts, CMS is ultimately a payer. So it does depend fundamentally on the on-the-ground clinicians and the organizations to relay exactly the type of technical assistance that they need, to relay exactly the type of data that they need. And I think that's the way that we're going to get the type of transformation that we really hope in this collaborative effort.
Yeah, and I'd just like to add, I've been very appreciative of CMS's efforts to engage with patients and communities and consumer advocates. I appreciate CMS's attention to focus the hybrid payment RFI questions that are important to patients and consumer advocates, around person-centered care, equity, and accountability. And I encourage advocates to consider engaging with CMS and vice versa on how they can ensure that primary care hybrid payments, for example, improve patient experience and outcomes, and how they can ensure that health inequities are not worsened as an unintended consequence, and how CMS can ensure that advanced primary care hybrid payment does actually increase access to health services for patients without a usual source of primary care, for example. So there are a number of questions in the RFI that I encourage all stakeholders to look into, but especially advocates.
Well, Sarah, you and the National Partnership have been real partners in advancing consumer perspective, and could not agree with you more that while a lot of this stuff seems very arcane, it has such profound implications on the kind of care that people can get. And so, joining with those who have already knee deep and putting together a set of comments in response, I think is going to be very, very important. And, across different, folks who are thinking about different populations as well. I noticed in the RFI, there was even a question about, pediatric care. So, I think we do need to think across populations. I think we need to energize consumer organizations to weigh in and provide their perspective. I think that's incredibly important. This new payment approach, the APCM, envisions hybrid payment. It's starting, fairly discreetly, but in the RFI, it suggests that this could eventually also encapsulate E&M payments and perhaps even go broader than that. But it suggests that this would be available both inside and outside of MSS ACOs. Some may wonder, how could this affect the work that ACOs are currently doing? And I'm just curious if folks who are, watching this sort of thing might care to comment. Really, maybe directed at you first, Amol.
Sure. So, I think in some sense we all, the collective we here, we're kind of chasing this this elusive ideal of greater investment in primary care. And even in ACOs, I think we see some variability in how much of that spending is actually going to the ACO, and therefore how much the primary care within the ACO, and therefore how much primary care can actually influence. So I think one of the key dimensions here is if the APCM construct works really well and is used very effectively, it should be a mechanism to drive greater spending within the primary care paradigm, which will enable more success in the ACO broader total cost paradigm. So that's one of the key dimensions, I think, at least aspirationally. We didn't quite hear exactly that from Liz Porva and team, but my suspicion is that's an aspect of kind of what the rationale here is in thinking about how this mechanism can function effectively.
Super. Maybe just a follow-up question. There are, Doug presented 3 different categories, if you will, depending upon the number of chronic conditions and social risk in terms of different payment levels. I'm curious, given your expertise in payment, what you think, those different levels would be worth to a practice. How when you saw those levels, what was your reaction, Amol?
So
proposed levels, I should say. They're not yet in regulation,
sure.
Proposed.
Yeah, I think I think the thing that was very striking is actually there was a pretty big breadth in terms of the RV, proposed and I think kind of hypothetical RVUs here that are estimated. That was pretty striking. I think on one hand, I think that's good in the sense that you see pretty large RVU type values for the qualified Medicare beneficiaries and those with chronic conditions. And I think because those really follow the beneficiary, one of the things that I think we're kind of, again, after here is that there should be essentially direct incentives, direct support for clinicians and practices that really care for more complex beneficiaries, both from a clinical perspective as well as the QMB piece of it also touches some of the socioeconomic aspects as well. So I think that's really nice to see. I think my reaction there was really positive on that part. That being said, I was pretty struck by the breadth. And I think to some extent, the question that popped into my head is, again, if we're trying to get enough dollars that are flowing through this part of the non kind of claim visit-based system, is that going to be enough if you have a practice that happens to not have a very large share of complex beneficiaries, even if there's still benefits to that kind of proactive infrastructure to actually do prevention and other pieces where we're trying to get ahead of the chronic conditions as opposed to chase our tail afterwards after the patient develops a chronic condition. So I think a little bit of really positive reaction and a little bit of sort of contemplation as well from my side on that.
Well, and that's where all payer alignment can really come in, because if Medicare obviously is a really important mover here, but not the only one, so it's going to be important to have all payer alignment. So, there is this notion of moving away from having to be tied to a certain number of minutes and all those time requirements, which does seem incredibly burdensome. And yet Doug listed a number of requirements that, need to be in place. And one of them is a care management plan, if you will. I'm curious, as you sort of looked at those list of requirements, recognizing you wouldn't have the same, time requirement on the other side, what's your sense of the administrative burden? Maybe starting with Amy, who might be closest to this.
Yeah, and I think Amol is spot on that, I still have some open questions on this. I'm still contemplating all of it. I think, for those that have the chronic conditions and the social needs, development of that care plan is already pretty much an expectation with how we do things today and very consistent. You just will lose the kind of the minutes and all of the other things associated with it. For that lower end complexity patient where it's paying, at the smaller RVUs, I think we have to think through what does that care plan look like? Because, what I heard CMS reflecting, and I agree that, care coordination benefits pretty much anybody, particularly if there's, lower health literacy or things, within the system where you just need that auxiliary support within the office to be able to help people get what they need and get to what they need. But what does that look like? Because it shouldn't be the same as a care plan that's constructed for somebody who has multiple chronic conditions, social needs, all of those types of things. And so I think the devil becomes in the details on this, and becomes at that point of care, how do we construct these things in a way that makes sense and doesn't increase the administrative burden at the office?
Thanks so much. Okay, so clearly this is, and we're just going to close it out here. CMS can't do this alone. If we get our community mobilized, as we know we can and have done in the past, and look forward to working with all of you and everyone who has joined our webinar today. What would it mean if, this actually was implemented in a way that, we got it right in terms of more usable, lower burden, greater investment in primary care? What would it actually mean for beneficiaries and for primary care practices? Very quick popcorn responses. We'll close it out and we'll have this webinar posted within 24 hours. Sarah, you want to start?
Sure, happy to. We hear all the time, patients and caregivers want a long-term relationship with their providers whom they trust and who, sees them as an individual, listens to them and treats them with respect, right? And I think this proposal rule really does help to strengthen and support those longitudinal patient-provider relationships that are essential for improving outcomes and advancing health equity. So that's what I'm excited about.
Thank you. Who else wants to jump in?
I'm happy to quickly jump in. So I agree with what Sarah said for sure. I would say, it'd be wonderful to see. I think success would really be if we see action on the fourth of the quadruple aim, which is the physician satisfaction, physician burnout piece. I think that would be amazing if we can really get action on that one.
Thank you. Amy.
Yeah, great one, Amol and Sarah, both of you. I would say it looks like a system that works for everybody, right? It's meeting the needs for our patients. It's meeting the needs as technology advances and how patients want to receive care. And it's meeting the needs across the span of a lifetime, which is what primary care is meant to do.
Thank you all. I really appreciate your comments. Look forward to working with you as we partner with CMS and the Hill to advance these ideas. Have a great afternoon.
Thank you.